started Barbell Medicine in 2012. I love this company. I bleed this company. It is, one of the best things I've ever done. And granted, it's my life's work, right? But I aspire at some point when I sell this or wind this down or whatever it is, I would love to teach at a university, ideally a med school, because I think, they'd be like, oh, you're a doctor guy. Like, you're one of us. And yeah, that'd be fun. I want to do that. And so to me, this is, I don't know, I'm getting my reps in. It's kind of fun. So it's like sport in a way, but also, I get to do some teaching. So it's fun. That said, people are assholes on the internet.
Team, welcome back to another week of the Mops and Mo's podcast. And this one is we're grabbing current events by the balls.
You still haven't used the ball knower thing? Do you want to work that one in because you haven't yet?
Oh, I forgot about that. Well, yeah, I'll do that after you introduce him. I totally forgot about that. We're trying to come up with as many puns as we could. We dropped the ball. Damn it. We dropped the ball. But before we get there, you have something.
Yeah, pre-episode, just a topic we got to get through here because I think it's fascinating and interesting.
Those are the same things.
Sure, synonyms. Peek behind the curtain. There's been a chat going on at Mops and Mo's headquarters about a potential job board type of tool for people trying to find jobs in tactical human performance, military human performance. So I've had an eye out for jobs in the space, right? And an interesting one came across my feed today. It did not list today. It listed like a week ago. But this is a job where the title is Director, Wellness Center for the United States Capitol Police. It's interesting in a few ways. One, I don't know how many people have like read far enough down in here to see the requirements. You must have a master's or doctoral degree in a behavioral health field. So like kinesiology's out, physical therapy's out. Most of those are out. And you must also be a currently independently licensed MD, DO, PsyD, clinical social worker, licensed professional counselor, or LMFT. So you do have to be essentially a doctor or a psychologist or some type of licensed mental health provider, which I find fascinating. It tells you what their concerns are in their program. So it's not necessarily like super physical performance oriented. It's very much behavioral health oriented. That struck me as unique as a director position. But what hit me the most is the salary for this position,
which is awesome.
It is awesome, but it also fits into a very interesting context in federal hiring. We've spent many episodes talking about like the contracting issues with military human performance, contracting versus GS or government civilian roles, where salary should be for coaches compared to where they are. But the salary for this position is a range from $221,979 at the low end to a cap of $228,000. Drew, does that strike you as unique in the federal system?
It's very high.
Do you know what grade it is?
No idea. Very high. It's a high grade.
It's SES 2.
There you go. You're a general.
No, you are more than just a general. You are like well into the general ranks. Drew, how many federal civilians do you think make more than that?
I roughly know this answer because we talked about it. It's like not 15.
It's 21.
There you go.
And those positions are codified in law because those are cabinet secretaries.
Approved by
Senate like nominated and approved through Congress. Those are when the president holds a cabinet meeting.
They go.
The people sitting at that table are the only people at a pay grade higher than this. This is one level down from them. So this is the same pay grade as the Secretary of the Army. It's the same pay grade as the Secretary of the Navy. It's the same pay grade as the Director of NASA. It's the same pay grade as the Director of the CIA, the FBI, the NSA. Like every independent federal agency that is not led by a cabinet secretary is the same pay grade as the Wellness Center Director for the Capitol Police, which is an organization smaller than a single Army brigade. I I don't necessarily have like a huge takeaway to end this rant with, other than when they tell you they can't pay you better,
They can.
they can. They just need to fight harder. If Capitol Police can get approval for a pay grade for their wellness center director that is the same as directors of entire federal agencies, it's possible.
That's so sick. You think that's real? Is it real?
I do kind of want to reach out to them.
I want to know how they did that.
Like, yeah, that's
Let's
some
reach
like
out to them.
inside baseball that the field should know, right?
Let's
like,
do that.
Agreed.
Apply.
Done.
If you meet those requirements, apply and let us know, and we'll come at it from the other end.
It is like to find somebody, because you have to have like experience equivalent to GS-15, and you have to be a licensed mental health provider. How many GS-15 licensed mental health providers do you think there are?
I don't know. Hopefully somebody slips into the comments. And
I
don't know how many GS-15s are in our comments, to be honest.
I don't think it's going to be a lot.
Probably not.
I got to check whether it's like open to people outside the government or if you have to be in the government already. I will have to go back and look at that one later because my eyes are like blurring over trying to read it.
If you are there listening to this, both Alex and I will do that work for you remotely for under $200,000. So just throwing that out there. I will sell out so fast. But you know who won't sell out? The ball knower himself, Jordan Feigenbaum.
That's correct, Drew. Our guest, Jordan Feigenbaum, second time on the podcast, right?
Yeah.
He is an experienced strength coach who also has his medical degree and residency training. So he's Jordan Feigenbaum, MD.
Doctor.
Yeah. In addition to his coaching and medical credentials, Jordan is also an elite powerlifter who, according to Powerlifting Watch, has one of the top 20 totals of all time. Got his bachelor's degree, bachelor's of science in biology from Truman State University. Also, essentially at the same time as that, for the coaches that listen to this podcast, he got his CSCS also in 2008. Then went on to get his Master's of Anatomy and Physiology from St. Louis University School of Medicine, and finally his MD from Eastern Virginia Medical School. Since we got a lot of powerlifting bros out there who were obviously wondering, I went on Open Powerlifting to find his stats. We're talking about a squat of 633.8, a bench of 435.4, and a deadlift of 733 for a total of 1802.2. And I am not a powerlifter, so those are less exciting to me, but I am a guy who dabbles in social media nonsense. And I will say that his social media game has been on point lately, and like not just effective in terms of getting engagement and being really entertaining and cool and informative, but as you'll hear him discuss today, he has also become a very positive presence in the overall pretty rough space that is social media health and fitness.
Also incredibly timely. Totally by sheer coincidence, he and Austin Brackey, Dr. Brackey, the other half of Barbell Medicine, published a book on testosterone and started generating a lot of content around, I don't know, testosterone misinformation, testosterone health, all these kinds of things. Right around the same time that the Department of War published this new policy saying that everyone's getting tested over 30, it's mandatory, et cetera, et cetera. You guys all know the policy by now. So those two things happened like relatively simultaneously. And we immediately were like, we got to get Jordan back on to talk about testosterone, if for no other reason than to like dispel, I think, some of the myths and the misinformation around what is now a pretty wild thing to think about, like the administration of TRT to service members. Yeah.
And he'll plug it at the end of the episode, so you'll hear it. But if over the course of listening to all this, you are interested enough that you want to learn more and want to go read the book, it is titled Signal: What Testosterone Levels Are Telling You About Your Health. And among a few other citations that we cover in this podcast, you will find a link to that in the show notes.
Boom. And I do want to say quickly, because I think it's very easy for folks to just assume like, oh, Mops and Mo's, they're going to take like the detractor position for the thing. That's not what we wanted to do here. Jordan, clearly, as you mentioned, full book on this, generating a ton of content on it. I don't want folks to come into this immediately thinking we are trying to tell you this is bad. All hell is about to break loose. All we wanted to do was have somebody who clearly knows more about this than we do give an honest assessment of what it could mean, how it could go. So there's certainly some stuff in here to hopefully better equip you with the right knowledge to take into this potential new policy. There's also some stuff in here to where if you are one of those folks that ends up like wanting to go down the road of testosterone replacement therapy, like hopefully some stuff that will help you stay informed as you continue that journey.
A theme I think you will discover over the course of the conversation, it's repeated a few times, is that we are missing on both ends on this one. There are people receiving treatment when they should not be, and there are people who are not receiving treatment that should be.
Yes.
So it is not as simple as like, this is good or this is bad. It's what kind of frameworks can we put in place to get a little more on target with our interventions?
Yeah. And, full disclosure, both Alex and I are juiced to the gills.
I mean, being honest, I would love to one day get a steroids allegation. I have not received one yet.
I mean, there's plenty of time. Yeah, have you seen both
at a
of
whopping
us?
Like 163 pounds, I don't think I'm attracting many of those allegations yet.
Yeah, and you've seen, like, folks have obviously seen all of the shirtless Mops and Mo's content that we generate. We're clearly on gear, huge advocates of any
I've
and
been
all.
considering leaning into more shirtless content, though. You want to contribute, Drew?
No, and I really hope you don't. Although, hey, listen, if it drives engagement,
there we
by all
go.
means. Folks should know Mops and Mo's is and always has been for sale. So with all that being said, strap in, prepare yourself. We're going deep.
You sure you don't want to like?
I don't have like a good testicle pun off the cuff.
All right, guys, enjoy the pod.
We're swinging for the fences here. This week's episode is brought to you by Teamworks. If you have performance data scattered across apps, spreadsheets, group chats, it means things get missed. Teamworks brings it all together. Training, nutrition, scheduling, communication, all in one platform built for the people responsible for readiness. Learn more today at teamworkstactical.com.
I feel like we got to start at a place that I see a lot of this conversation orbiting around. So I'm going to open with a question, which is, I've learned it from every source on the internet I possibly can. Men are just less manly than they used to be. Testosterone levels are falling off a cliff.
Sure, let's do it.
Is it true?
Yeah, no. So it's been popular to say this for a long time. I don't know the origin story of like, we becoming less masculine, or even just the source of the claim testosterone levels are dropping. I know the academic source of this. This is from a study done by Travison in 2007, where he found that birth cohorts, which is a fancy way of saying men who are the same age when they're tested, but born a decade apart, 15 years apart, whatever. And so you're just looking at different groups of people that are born in different time periods. He found that there was a drop in testosterone from birth cohort to birth cohort, right? That's subsequently been shown in about 3 relatively large studies. And on average, when you group you kind of combine all this data together, you roll it around in your head and you say, all right, well, what is the average decline? It comes out to be about 1% per year, right? Since like the 1970s. And you're like, well, shoot, if that math is mathing, then we're, 50% down. That's how the math works, right? And some people, the bolder people will say something like that. Less bold, more moderate would say, 20% is what it's gone down on average, right? it's a compelling story. Look, if our testosterone level is dropping, and testosterone is the thing that makes you a man, ignoring all of the other things that go into that, sure, I'm with you on this. Okay. Is it true? That's the first thing you have to do. And so what's happened recently is there's been they're not data sleuths. They are very smart analytical chemists and other clinical researchers. What they've identified is that all of these studies have two major things in common. Thing one has to do with the testosterone test itself. Now, prior to around 2000, the only way that we could test your testosterone level was using a test called an immunoassay. It's just all you need to know is it's a test, and it is not very accurate, period. But it's especially not very accurate when testosterone levels are low, right? And so at that point, the low clinical criteria for like a lab cutoff was about 300 nanograms per deciliter. It is very inaccurate there. It tends to read high. Okay, it tends to read high. Now, this new test comes out, mass spec, comes out around 2000. We don't really start using it until years later, okay? But as far as like for population studies, but it is very accurate, very, very accurate. And so this decline that you see 1% per year, right, or decline amongst birth cohorts, generally only shows up when you compare immunoassay study to mass spec study. And so you have an artificially inflated number and then a very accurate number. So it creates this trend. And so one way you'd want to test that, you'd want to say, well, look, okay, if what you're saying is true, Dr. Feigenbaum, all right, well, I'm with you on this. Is there any large data set for a long period of time that uses just the really accurate test? And in fact, there is. In over 100,000 people, 30 years of data, okay, they use just the mass spec, there's no decline. Okay, well, that's only 30 years. Well, what if we go back even further? Is there anything, can we do anything about this? Could we use maybe some of the old blood that had been stored and banked? Could we run an accurate test on that? So what they've done is they've taken data from even further back, and they use, it's granted an immunoassay test, but they ran it on the same day on the same platform, which does minimize how much the test can kind of, the noise in the test. And again, no decline. And so, all right. So you look at that and you're like, all right, I'm kind of with you. All right, but is there a second? Something, there's got to be something going on. Testosterone levels has to be going down. I just know it. I feel it in my, to Will Ferrell's character, in my plums from.
It's a great reference for a testosterone.
Sure, yeah. Feel it in my plums, right? And so there's kind of some nuance here. And the second problem, which is really a two-parter. Problem number one is, as early as around 2014, 2015, it was identified that there's been like TRT contamination in testosterone levels, okay? And so there was this concern that when we do population studies on testosterone, you'll see like an artificial increase, or in this case, maybe an artificial steady state of testosterone, because testosterone prescriptions have gone up a ton in the United States, quadrupled or 5x, depending on the data set you use, so a lot, right? And in women too. And so when you look at that, you're like, okay, well, if there's TRT contamination, then that means there really is a decline. Okay. And so is that decline present? And if so, what's causing it? Is it Monsanto? Is it the glyphosate in the crops? Is it, acid rain? What is it? Endocrine disrupting chemicals. If I'm being serious for a second. Well, the other thing that's really changed, and it makes sense with the timeline, is obesity has gone up. Obesity has gone up. Now, if you go back to those 3 huge studies that all show, look, it's 1% per year, they'll say right in there, look, we corrected for obesity. And the test they use is BMI. And the problem is BMI is a relatively poor proxy for body fat and body fat distribution in particular. So the way I think about obesity being a disease of too much body fat, which kind of is self-referential if you think about it. What does too much mean, right? It's the point at which it starts causing harm. And you're like, okay, so you're calling it a disease, and it's only a disease when it causes disease. It's like a little tautology. So the way I think about obesity is that it's too much body fat, and it becomes too much body fat once it outstrips your ability to store it safely. So you can think about, you have a garage, right? You have a garage. This is your body fat storage. You can put all the boxes you want in the garage, and your house is clean. You don't trip down the stairs. You don't have stuff in your room that shouldn't be there. When everybody's got their own sort of genetically predetermined, in many cases, garage size. Some people got a 2-car garage. Some people have a shed. Some people live in an apartment. They have no garage at all. And the point is, once they've outstripped that amount of storage, now they're putting boxes in the house. They got a box in the kitchen. They got a box in the living room, in other rooms, in the stairs. And if they're not moving, right, you carrying a box up the stairs, not a problem. But if it's on the stairs, you can trip over it. So once you've kind of outstripped your storage and it gets and sitting there somewhere, that's when it causes harm. That's really what obesity is. And in particular, when it comes to testosterone, when you have this visceral adipose tissue, the belly fat right around your internal organs, when that fat mass is there and it's sedentary, it's sitting, it's not turning over, a term we call flux, it lowers testosterone a ton. And BMI is terrible at picking that up. So the whole point is this: is there a better test at identifying visceral adipose tissue? And has somebody done that and tracked testosterone levels in a ton of people over a long period of time? And in fact, they did. There's a study of over 100,000 people. Okay. And they did a waist circumference, which is a really great way to see, is somebody carrying too much body fat? That's why BMI, its biggest problem is that it's not over-diagnosing people that are too jacked as obese. There's not a lot of those people walking around anyway. The biggest problem is that when people don't have a BMI over 30, right, it's saying, look, you don't have obesity at this time. And in fact, they are carrying too much body fat, which you could identify with the waist circumference. So most organizations now recommend getting a waist circumference too. So this study, 100,000 people, 30 years of data, did a waist circumference. And that directly tracked with testosterone levels going down year over year. And so all of this is to say, there is no secular decline that we can identify in testosterone. Secular meaning it's not due to a medical condition. It's due to something in the ether, in the environment, something that everyone gets exposed to. It's really obesity to the extent that it's there. And I suspect it's on average maybe 0.25% per year, maybe. But mainly that corresponds with the rise of obesity. All right. I know it's a longer answer than what you were thinking, but like,
no, that was beautiful.
That's well, we just wrote a book on this. So like it's all here. And so,
well, I have to ask you and I'm glad you mentioned that, because like the DOD policy dropped, and that just like in our world was insane. And it seemed to just so serendipitously line up with when you guys started putting out a lot of high quality information on testosterone. Was that totally just luck on your part? Like, you guys are the pros now.
Pete Hegseth didn't call us and say, hey, look, we're doing this test thing. If you wanted to market it, like, here you go. But I mean, if you think about it from our perspective, we've been getting fielding questions on testosterone, since our inception, since 2012, right? And mostly that's from the resistance training side or from the performance side, we'll say, when people are like, look, my squat isn't going up as much as it should. I'm not getting as much muscle mass as I should. I need more testosterone. And to those people's credit, look, if you have testosterone deficiency, which is identified as not only having laboratory evidence of a lower than normal testosterone level, but also symptoms. You have both of those things, and you restore that person to a normal testosterone level, what we call eugonadal. All right. Yeah, it could be life-changing for them, right? Not only just in the gym, but just mood, sexual function, everything else. And also even health status, like a number of other health markers. On the other hand, and this is where people get into trouble, and this is where I think this policy runs into trouble. If you have a testosterone level that's, we'll call it low normal, for example, right? But you don't have specific signs of testosterone deficiency. These would be things like, I mean, there's a whole compendium of like, these are very specific, like hair loss, testicular shrinkage, or whatever. And then moderately specific, where people lose a libido that was previously normal, for example. And then there's general stuff where you're like, I'm tired. And you're like, there's like a million things that can cause you to be tired, right? If you take somebody who doesn't have specific symptoms or even suggestive symptoms of testosterone deficiency, and they're low normal, let's say they're 350, right? And you put them up to 700, and they're like, yes, now I have the masculine hormone, it's higher. Their training outcomes don't really change in general. Yeah, this has been studied. There is a dose-response relationship to testosterone in really two scenarios. One, you go from low to normal, or you go from normal to super physiological, right? And then the problem here is a little conflation with they're not old wives' tales, because wives aren't telling these things, right? So maybe it's old bros' tales.
Old husbands' tales.
Well, somebody gets put on TRT and they gain, 10 pounds of muscle, right? And they're like, dude, my buddy got on TRT and now he's jacked. Yeah. The majority of TRT, it's unfortunate that this whole system fails in two different ways, and the opposite ways. The most common way it fails right now is that people are getting over-treated mainly people who don't need it are getting put on it, and they're being dosed at a level that's too high. So they're actually super physiological for the majority of the time that they're on it, which is why they see the, result that you see. They're like, look, I gain muscle, I get strength, whatever. And it's like, well, yeah, you're kind of on a low dose of gear here at this particular time. It also fails the other way, where you have people who have genuinely low testosterone levels and or symptoms, but their physicians that they see are not comfortable treating them. So they don't actually get what they need. So it fails both ways, right? The whole problem here is the workup, which is honestly speaks to this policy. Some of the concerns we have around the policy. It's like most people will not get the correct workup. And then most people who didn't get the correct workup won't get the correct aftercare, whether it's ongoing lab monitoring, dosage adjustment, this, that, and the other. And so from a medical perspective, that's a real risk. And this, testosterone can be great and it's generally pretty safe, but that assumes a lot of things that aren't really happening when this is being managed.
So I gotta hit one. First off, if people want some fun anecdotes, the website for their book is fantastic. It's got a lot of fun little excerpts. I don't know if we'll be able to work all of them into the conversation today.
Okay.
But I love like a little bit of a gotcha moment. So I'm going to attempt one here. We'll see how it goes.
All right.
You have in the stats for the book that 1 in 4 testosterone prescriptions over like a 10-year period were started without any confirmation, like no lab work whatsoever.
No lab work.
You also say that 55% experienced remission without intervention, meaning like people who are identified as low T, no intervention whatsoever. Next time you test them, they're back to normal. But then the last one, you said 38.7% of men 45 and older meet criteria for testosterone deficiency, but only a minority receive treatment.
Yep.
Where I want to attempt the gotcha is that on that last one, you have a separate post where you say the citation for the first one is Mulligan 2006, International Journal of Clinical Practice. But you've also cited Arajo 2007, Journal of Clinical Endocrinology, where it says that 1 in 18 men 30 to 79 have testosterone deficiency, which is 5.7%. How do we square 38.7% of men 45 and older meeting criteria with a different study saying only 5.7% 30 to 79 are symptomatic androgen deficiency by their definition?
No, that's a great question. If you look at the dates on the citations, what you'll see here is basically an evolution of what we thought about previously. It was called male hypogonadism. Now it's called testosterone deficiency. And the biggest things that have changed is sort of this basically requirement now that you have not only laboratory evidence of low testosterone, but in addition have symptoms. So the 38% stat is mostly laboratory evidence only. Like you have a genuinely either low or borderline low testosterone level. And then the other one is that plus symptoms. And so that's genuinely lower. The problem
Annoyingly, that is what I read in Arajo. They do explain that.
He just
the numbers about
he came
double
back
that.
with a haymaker. He just started like jab Tyson. He's like, get out of here.
No,
it is true that the study reports like a 9 to 10% rate when you say lab only, 5.7% when you say lab plus symptoms, which is their definition for deficiency.
Yeah, which is a perfect tee up for this. If you were to screen everybody, and particularly in the military, right? Mainly, if you focus on the military, what you're going to pick up, you're going to identify some people with genuine testosterone deficiency that otherwise would have never been tested, right? Or at least not tested in the military unless they actually went to their provider and said, hey, look, I've got these signs and symptoms, and the provider did the appropriate workup. That's how you hope this stuff happens, right? But it doesn't always. So you're going to identify some people who genuinely would benefit from being identified and subsequently going on testosterone therapy. You're going to also identify people who, for whatever reason, at that particular time tested low. And in the military, as you guys well know, the environment is not conducive to you living your best life. Sleep, food, stress, all sorts of stuff, right? And so you'll see those people who are going to be flagged low, and it's an environmental cause. And so really the fix is to treat the environment, fix the environment versus the testosterone. So you're going to get these sort of people who it's not a false positive because they still are low, but they won't really benefit from the testosterone replacement because the environment is still pickled. All right. And then further, you're going to identify people who aren't really low, but there's such variation in your day-to-day testosterone levels that they're going to be flagged low. And then if you tested them again, they're going to be normal. But most people don't get that secondary test.
And the military testing is part of an annual assessment.
Mm-hmm.
As
Which is a problem. Yeah. And so even in the military's own medical data that they have on this, on how they
Mhm.
do TRT and like the VA system, less than 3% of those who are on TRT right now are getting the right care. And it's like, I don't know that adding more to all of the clinicians in the military medicine system is, I don't know that it can be handled appropriately. And so I have some real concerns. That said, testosterone is relatively safe. I'm not trying to raise some alarms here, but inappropriate medical treatment, I have real concerns about that going out at large, especially if it's under the guise of we want our soldiers, you know, aggressive and high
Mm-hmm.
T and whatever. And it's like, I just want people to have normal testosterone levels. Okay. Like, is that
What
weird?
are like, I mean, I don't want to use the word, maybe I do. Like, what are the risks, I suppose, of like, you mentioned all the underlying factors that could lead to suppressed testosterone. And we've talked about these before, and everybody knows them, like shitty sleep, social connection, yada, yada, yada. We jack up that T number to what we
Mhm.
perceive to be normal, but we don't change any of the environmental stressors. What does that do to a human? Does that make sense?
Yeah. Yeah. So you have somebody who's got an environmentally suppressed testosterone level, and now you're artificially inflating it.
Yeah,
And
but we haven't fixed any of the things.
so let's set a few of my real concerns aside in that most TRT today is overdosed. And the problem and how you see that is you measure what people's testosterone levels are in between doses. Right now, it
Mm,
depends on the type of testosterone they're taking, when they're measured, like in their whole like are you right directly between in the middle of two shots? Are you closer to the end or whatever? So there's some squish here, but you would prefer people to have on average a mid-range testosterone level. That's what all of the guidelines say when you're doing testosterone replacement. So somewhere between like 450 and 600 on average. Well, in the largest study ever done on this, it's over 800, which suggest, and that's the average. All right. So that
mhm.
means a substantial amount of people are being overdosed, right? And we don't have great safety data there. Okay. For example, the heart data that we have suggesting that, look, people on TRT don't have more strokes, don't have more heart attacks, whatever, right? One, they were using the gel, all right?
Mm.
And two, when they were replacing their testosterone levels, it was only to like in the mid 300s, high 300s, right? And so now you got people walking around their testosterone levels 800, 900, or 1,000. I have some concerns there, right?
Yeah.
Okay. For example, that's just one thing, right? And if they didn't
Can we
get the
talk about
appropriate,
what those concerns are real quick? Because this is one I found. I gave a class earlier today to like an Army National Guard unit, and they asked about testosterone, obviously, because there's stuff
sure.
going on in the Army that they want to know about. And and it seems like there is little to no awareness of side effects with TRT. And I want to run a few by you to see how real they are.
Yeah, let's do lightning round. Let's do it.
Uh,
Boom.
First one, infertility.
Yeah, a big risk. Effectively, even very low doses of exogenous testosterone. So even ones that would not put you into the eugenatal range, right? So you could take enough to shut yourself down, your own body's testosterone production down, but still have low testosterone. Imagine somebody taking like 25 milligrams per week of injectable testosterone. They're never going to get to a mid-range level or even a low normal level. They're going to be low, but because the body's getting exogenous testosterone, it pretty much shuts down. And so that also shuts down spermiogenesis. So you have less sperm production in many cases, becoming infertile, and that goes up with dose. Like the higher the dose, it becomes even more prominent. There are ways to work around that. Some other medications that people can take to not become infertile. But the most interesting part about the infertility, urologists who are genuinely supposed to be like some of the most educated people in this space, and many of them are, to be clear, they're very bright. 1 in 4 was unaware that giving testosterone would actually make somebody infertile when it's like one of the
What?
major. Yeah, and I should also say in this, when people come off testosterone, generally speaking, most people will regain fertility unless they were on a high dose or on it for very long. And sometimes that takes even longer for your spermiogenesis to come back, but doesn't always, right? So there's a real risk there, especially a person who really desires to have children. And that's got to be a part of the discussion. So infertility,
Mhm.
yes, very significant risk factor. Can be avoided again if everything's done by the book and done well, but I have concerns that that's not really what's happening here.
Next one, and this one I get the whole thing of like correlational data versus causational data, but tendon and ligament injuries.
Yeah, no, this is actually a pretty interesting question, near and dear to my heart, especially being involved in like strength power sports, where
Mhm.
we'll just say that the use of testosterone amongst other agents is relatively common. And this is a signal we've been trying to parse for a long, long time. There's some, I would say, reasonably well done studies that have tried to identify the unique signal of testosterone, or in more general cases, and exposure to anabolic androgenic steroids, AAS. You don't really see it. In a petri dish, you can see some sort of weird stuff happening in the cells that ultimately, contribute to making ligaments, tendons, or whatever. But that doesn't necessarily play out in humans. What we think happens is folks' strength, their
Mhm.
muscular force production goes up at a more rapid rate than their tendons. Now that happens
Mhm.
naturally anyway,
Yeah.
right?
Mhm.
That's why like pushing too hard, too much, too soon, tendonitis is a very, very common outcome in when people train a lot. It seems to be like amped up. I would just say like tendinopathy risk on steroids if it weren't like exact thing that we're talking about. So so my take on the injury risk with respect to like tendinopathy, ligament rupture, something like that, it's mostly a positive feedback cycle that people get. They start on these things, they get stronger at a much more rapid rate. And then instead of controlling training load very, very well, they're motivated to just keep pushing because why wouldn't you? You get a bunch of muscle, you feel awesome, you can recover or whatever. And then, yeah, flying a little too close to the sun. To me, it's mostly a training load thing. But to the extent that taking testosterone, particularly at higher doses, kind of exacerbates that positive feedback loop, I think that's the real mechanism there.
Mm.
Makes sense. Next one's fuzzy. It sounds like it doesn't cause it, but it can accelerate it. Prostate cancer.
This is actually super interesting. Okay. And there's a lot of the stuff's brand new. And so if you're listening to this and you're like, bro, this is way over my head or my eyes are going blazing over, you're talking too much science. I get it. Me too. We're aligned here. So for a long time, it was thought that if you raised somebody's testosterone levels, that period, they're going to be at an increased risk of prostate cancer. That does not seem to be true. What the model that we think explains this is called the saturation model, where effectively once you get up to around 250 nanograms per deciliter, somewhere in there, more testosterone doesn't do anything to the prostate. Okay. Now, people who have active prostate cancer, right? That's a different population.
Mhm.
Those folks, there's some specific hormonal management that generally benefits them. ADT is one of the hallmarks of that therapy, androgen deprivation therapy. Okay. But let's set that aside. Test TRT, we have pretty good evidence showing it does not increase the risk of prostate cancer, right? Another interesting thing here is that people who have previously had prostate cancer, had it removed, had it treated, they also are candidates if they need it for testosterone replacement therapy. It does not increase their risk of recurrence. But the most interesting thing that's been coming out is that low testosterone itself seems to be a risk factor for developing prostate cancer. What we think is
Mm.
this low testosterone environment, or as the famous physiologist Claude Bernard would say, internal milieu or
Yeah.
testosterone milieu. Basically, what the prostate is bathing in testosterone
The
wise, when it's
milieu.
low testosterone, yeah, the cells do weird stuff. Higher rate of mutations, and these mutations tend to be funky, and it can drive more aggressive prostate cancer. So it's thought that low testosterone kind of creates that environment for these highly mutagenic cells to grow. Whether that's due to the generally poorer health of people who have low testosterone, or it's the low testosterone themselves, that's harder to parse. And maybe that's just a brief aside for folks. Testosterone, to me, the way I view it, your testosterone level, particularly as an adult, is mostly a readout of your current health status. If you are relatively lean, active, otherwise don't have medical conditions, type 2 diabetes, high blood pressure, heart disease, so on and so forth, you, your testosterone level is kind of like a readout on the dashboard, like, oh, things are good. And if it's lower, to me, that suggests, all right, we have excess body fat in the wrong place, right? Too many boxes in the stairway, right? Or we have another medical condition that in and of itself is contributing to low testosterone. And so the idea would be, well, should we attack those things first and then
Mhm.
see the testosterone commensurately go up? That is a reasonable idea. Or, and particularly in the case of obesity, which is the most common cause of testosterone deficiency right now. So it's like, well, should this person get testosterone or GLP-1? It's like, maybe a GLP-1, maybe both. That's the study I would like to see. Call it testosterone terzepatide. Let's do it. Let's see what happens. But yeah, from a prostate cancer perspective, though, this is like new stuff, bleeding edge. And I think I found it very, very interesting.
Final one that I'm aware of: heart stuff and blood clots.
Yeah,
Hard stuff.
hard stuff. I like that. Okay. So the Traverse trial basically was the thing that came out in 2023. They took 5,000 men with pre-existing heart disease or otherwise high cardiovascular disease risk with testosterone deficiency, and they put them on TRT. Now, the thing was, again, this is the gel. They only replaced their testosterone levels up to like in the 300s or whatever. So they're not getting like a ton of T. And basically it was a non-inferiority. They basically showed, look, there's not a big risk of increasing the risk of heart disease. It didn't show it prevented heart disease. Right. So, and then there was a little signal that they might have more clots in their lungs, just like a very small signal there. I think there was acute kidney injury signal there too in a few patients. But stroke, heart disease doesn't seem to go up when testosterone levels are replaced to normal levels. But again, there's a little asterisk there. It's like, we don't really know that with the injectables, and particularly when testosterone is dosed higher, because we see a lot of, we'll just call it deleterious remodeling of the heart, in addition to other risk factors being exacerbated, like blood pressure, the amount of formed elements, red blood cells, for example. You can get erythrocytosis, so too many red blood cells are being formed when the dose is too high. And those are all risks for some sort of cardiovascular related disease. Again, mostly happens with higher doses, inappropriately higher doses in particular, and then when they're sustained for a long time. So the way I think about the heart disease risk is as follows. If somebody's got low testosterone deficiency, I think they're at higher risk of heart disease because of the conditions that have put them in the position to have testosterone disease or testosterone deficiency. So it might be obesity, for example, type 2 diabetes and obesity, metabolic syndrome, whatever, right? That's a risk there, and you'd want to replace that person. But if you go too high, I think the risk also picks back up, if that makes sense. So I think ultimately when you put people in the appropriate range, if they're appropriately treated, I don't think there's a big heart disease risk there. The caveat being, I still want longer term, multi-year data using an injectable, how people are normally using this at the levels that people are normally using them at. Now, you would think, look, if testosterone prescriptions have gone up 5x, whatever, right, in the last 20, 30 years, where are all the bodies? Where are all these heart disease? But right, that kind of leads to the next point. Most people stop taking this stuff within a year of starting.
Ooh,
Most
interesting.
people, yeah, like 70% of people discontinue use. And actually it gets, I posted about this and some guy was like, no, that study, the first study that you quoted was just mostly on predominantly the gel. And I'm like, yeah, but when you look at injectables, it's not much better. In fact, in the largest study we have, it's actually worse. And so that kind of begs the question. It's like, well, why are people stopping? And to me, my read of that is not because people are experiencing weird side effects, right? Or that the medications are expensive. Generally low side effect profile that people can notice and feel. Generally very cheap, right? It's just that it didn't do what they thought it was going to do, right? The other factor, and if I'm being honest, and I want people to know that I'm like an honest broker of information, I'm not trying to sell you anything except for maybe a book if you want to learn more about this.
Link in the show notes.
Yeah, right. Link in the show notes. They call people stopping this stuff, it's really discontinuous use in some of the studies where they don't continue to use it week over week over week or week. They have a more than a few weeks break in between doses. And so they call it discontinuous use. And then there's another category where people stop using it altogether for the duration of the study. So you got to parse all that. So it's kind of challenging to read. But I just want people to know I don't just read the abstracts. I actually get into the studies. I read the whole thing. And then I try my best in the book to communicate, well, here's what we know. Right. And so if I'm being an honest broker about this to the heart stuff question, I think it's mostly neutral with the exceptions of if you were previously low, I think getting you back to normal is probably benefit. And then if you go too high, I think that's probably risky. So that's as easy as I can say it.
Fair enough.
100% of NFL teams, 100% of NHL teams, 87% of NBA teams, they all trust Teamworks. The tech platform powering elite sport is now powering military readiness. Learn more today at teamworkstactical.com. Team, this episode of Mops and Mo's is brought to you by Train Heroic. Train Heroic is a reliable, well-designed platform for programming, tracking, and communicating with athletes. If you've been with us for any length of time, you will know that Train Heroic is the platform that we use to power our own training, long and strong, which you can find at our website, mopsandmos.com. If you're looking for a solid platform to support your own coaching, whether it's your full-time role or a side hustle, Train Heroic is definitely worth checking out. You can use the link in any of our show notes. You can find it in our newsletter, or you can head to our website, mopsandmos.com/training to get your first week for free.
For this next one, I'm going to give it context and say we live in a world today where there's this like assumption that more information is always better. More data in particular is always better. Like the more we know, the better decisions we can make. So I want to ask, the Endocrine Society and the American Urological Association both recommend against population level testing and screening. Why?
It's a great question. Most of them kind of point at overtreatment is the problem. Effectively, once you see a low number, people tend to get pretty motivated as far as like doing something about that. And if you remember back to the beginning of this episode where I'm like, look, most people don't get the appropriate workup, right? They either don't get the secondary value, they don't get a full workup to identify other causes of why the lab may be weird. They don't get their symptoms checked, for example. So if you inappropriately treat people, I think risk generally goes up. And so that's really what they're getting at here. The test itself is not expensive, right? Even the good mass spec test, but you got to do it right. It's got to be done first thing in the morning, fasted. You got to do 2 of them in short succession. You have to, when you get the second one, you have to get another set of additional labs to figure out where in the system is there a break, and or is there any other contributory causes? And most people don't get that. And then after that, the problem, if you just start somebody on treatment, you got to monitor them, and that doesn't always happen, which is another problem. So I didn't write the guidelines. No one called me up and said, "Hey, what do you think, man? Should we test everybody?" But it seems like they're mostly pointing at either over treatment or inappropriate treatment, which would stem from a universal screening sort of situation. Now, this is speculation, right? Because again, nobody called me and was like, "Hey, this is why we did it." Um, I I think if they had some guarantees or at least a big signal that this was really, really underdiagnosed and a lot of people were unnecessarily suffering, and so if you screened people, you would generally benefit the health of the community, they'd probably be on board with screening, right? But that signal's not really there. Yes, there are people certainly who would benefit from treatment who are currently not being worked up, but that's a relative minority compared to the amount of people who get overtreated, right? So it's kind of, you're failing in both ways, but I think the bigger failure right now is the overtreatment. I think that's where they landed too. And with respect to the military context specifically, the majority of the testosterone deficiency that's showing up in the military by their own data is from the environment. And so then you're like flagging, you're like, yeah, the environment's not great. And you're like, we knew that, dude. We knew that. There's dip and Zyn at everywhere, right? There's energy drinks everywhere. No one sleeps. And, so I don't know. I think my biggest problem with the idea that everybody in the military over the age of 30 is going to get screening is not that they have the information. It's just that the information is going to be acted upon in a way that ultimately harms health, to that individual. And what you would hope instead, the trigger would be symptoms. So for example, if they did this, if Pete Hegseth calls me up and says, Jordan, what do we do? What should we do instead? I'm convinced. Let's not do.
I read your book.
Yeah, I read your book. Let's not do the lab test. What do we do instead? You can do an inventory of symptoms, right? That one, you're not sending everybody to the lab. It's free. They just fill it out once a year. And if you have the symptoms, then cool, boom, triggered. You get to go to the lab because now you've identified symptoms that are indicative that you may in fact have testosterone deficiency, which if you do have, would likely benefit from some sort of treatment, but you have to be worked up properly. And so that's the way I would do it. And that's the way, if I was seeing patients every single day in the clinic, that's exactly how I would do it too. If a guy asked me, hey, I want to check my testosterone levels, I just want to know. And I'm like, I would ask him a series of questions about his sex life, about things that have been changing recently. Just try to get a sense of like, does it smell like testosterone deficiency to me? And if so, I'd be like, yeah, you know what? It'd be reasonable to get this information because then we could I could interpret it better. But when people say, oh, I just want a baseline, I'm not gatekeeping. I'm not saying, look, there's no way I'm ever ordering this test for you. I just need to put that into context, where it is, where I say, I don't think this is going to benefit you just having a baseline over time
Mhm.
because there's such a huge change in your testosterone levels, not only day to day, but week to month, year to year. And it doesn't really matter if your testosterone level goes up 100, goes down 100. It's not better or worse. It's just all in the normal range, which is great news because your body is resilient and robust and can adapt to all these different levels. And so, but if they still wanted it, I'd say fine. But you'd have to know all of this ahead of time. And if you and to your point, that's just more information. And in that case, I'm giving them more information to kind of help them contextualize the number.
Mhm.
That's how I think about it.
I do want to take a second. I wasn't sure if I'd work this into the conversation or not, but I have to get on a pedestal for a minute too.
Oh boy.
Um, you talked about like military specific data, and I have to address one military testosterone data pet peeve,
Yeah.
which is that researchers love to study what happens to service members' testosterone when they do austere field training in
100%.
particular.
Yep.
And then we love to extrapolate from that that there must be this broad testosterone problem when that data says the opposite. So I won't rant for too long here, but like for listeners, I will put all of these in the show notes. I'm going to drop you like 10 citations, all from the last 10 or so years. And in every case, you put people out in the woods and you make them work really hard and you limit their food and you limit their sleep, their testosterone plummets.
Hmm.
In some cases 40%, in some cases 90%. There's a ranger school study from 2000 where they reached like castrate levels of testosterone while they're in the field, like extreme drops in testosterone.
Yeah.
And in every case, every single study I have looked at, with between 3 days and 2 weeks of coming out of the field and getting to live life like a normal person, it returns to baseline every single time. So
Yep.
like I just get furious every time there's a citation that is like, oh look, testosterone drops when you spend 3 weeks in the woods and you're sleep deprived and you're starving. Like,
We
cool. Doesn't help the
we
conversation.
we see that even outside in civilian populations, particularly athletes, when there's low energy availability, for
Mhm.
example, right? So people doing high amounts of exercise volume and they're not eating enough to keep up with that, they can see their testosterone levels go down. Interestingly, it doesn't often produce symptoms. So we have a whole name for it, exercise hypogonadal male condition. But the only other thing to put a little bow on your military data, because I agree with you 1,000%, the two controlled trials the Army ran that actually gave soldiers testosterone during simulated field operations, while lean mass was protected a little bit. Now, the way they measured it is probably mostly fluid, specifically because these things didn't last that long. You can't really grow muscle in that time, but you can lose lean mass, which is mostly water, glycogen, as you guys know, something like that. In both of these studies, giving them the testosterone failed to protect performance as measured by strength, power, anaerobic and aerobic capacity. They declined about the same as those getting the placebo. And so then you're like, well, look, if we identify this stuff and then we treat this stuff, the people still don't do better in the time that we want them to be doing the best, which in this case would be, when they're out in the field. It's their army's own data. So it is very curious how they came to this idea. And I'm sure that other people much smarter than me had voiced their concerns and ultimately kind of rolled over and said, well, fine, you want to test it? Fine, just do it. Just do it. We're sick of having this fight. We'll run the test for you.
What do you kind of flipping this around? Like, because in my space, like there's a lot of people really excited about this, right? Like, oh, sick, the Army's going to give me TRT. Um, what do you say to folks, presumably guys, who are excited about this, want to do this, test low, quote unquote, do the thing, get the dose? What does that look like for them long term? What is the best way to go about this? How do they sustain it? What should they know?
Yeah, it's a great question. So to be clear, like if somebody wants to be on testosterone, I personally have no problems with that. I just want them to go into it with eyes wide open, right? And so we know that there are known risks. There are known benefits. And then there's some unknowns that we try to address as much as we can with monitoring, right? To the extent we know and it's feasible for us to monitor for certain things. So let's say somebody is, yeah, I love this policy. If I was low on T, I want them to flag me and I want to be treated, whatever. Sure, great. A few things. You'd want to make sure that you're worked up appropriately. You got 2 testosterone levels that have been taken prior to starting therapy. You want to have the fertility conversation. You want to make sure they identified that your body itself, there's some issue in your own body's ability to produce testosterone. Either you're not getting the right signal from your brain to the testes, right? Or the testes are receiving the signal and not able to produce enough testosterone. You'd want to identify like where's the problem? Because they generally can have some different management. It's not always just everyone gets TRT and that's the end of it, right? So that's thing one, making sure that they got the appropriate workup and that they have no what we would call contraindications to starting TRT. This would be things like, look, your red blood cell counts through the roof. You got erythrocytosis already. You have untreated sleep apnea. You've got your prostate cancer screening, for example. A number of things, right? So you're worked up appropriately. So assuming all that takes place, great. Now you're on testosterone replacement therapy. You'd want to make sure that early on you're getting some additional, more frequent monitoring to make sure that your levels are in that mid range, usually between doses. So if you're dosing yourself once a week or twice a week, that in between doses, your level's not at 1100 or 1200, right? It's 600, 700, something like that, right? Like sort of in that mid range. So you're not getting too much. So by the same token, you don't want to be dosed too little. So you want to have that. And then you want some additional monitoring to make sure, oh, your red blood cell count didn't go through the roof. So those sort of things to make sure you're on the right dose. So assuming all of that has happened, now long term, that interval frequency of monitoring becomes more protracted. So now it's every 6 months, for example, every 3 months to get your lab work. And again, just getting it regularly, having it monitored by a professional. And I think at that point, it becomes more a similar sort of recommendation to general health promotion. Okay, you're getting a lipid panel periodically. You've got an apolipoprotein B if needed because your lipid panel, there's some weird stuff, but you're not sure how to parse it, right? You're getting your blood pressure checked regularly. Your other medical conditions are being screened for and adequately managed. That's not unique to a TRT patient, right? However, because there might be an additional risk factor there if dosed inappropriately, you'd want to keep an eye on those sorts of things. But ultimately, yeah, it's a monitoring thing, and there's just not enough eyeballs. I think if testosterone prescriptions were going to go up another twofold from where they are right now. And speaking to that, and the thing you asked me, like, look, are testosterone levels falling, or is the sky falling, or guys becoming less masculine? Well, look, if you just look in the United States in the last 10 years, our average testosterone levels in the population have gone up by about 9.4%, which we think is mostly due to TRT contamination. All right, and so if there's that much TRT going out there and the monitoring is so bad, this would make it potentially worse. And so I just assuming that somebody's looking, somebody's watching, looking out for your best interests. I don't think you can have that assumption. So mainly just a little bit more health vigilance, I think, would be the idea, the overarching theme here. There are TRT clinics that would gladly put people on testosterone and an aromatase inhibitor, for example. But there are problems with that because these are usually generic sort of protocols. And if your estrogen level, for example, is too low, you can have all sorts of side effects, including gaining fat mass that you didn't want, for example, problems with libido, all sorts of interesting things. And so, again, the monitoring thing is the big issue, both before and after. But yeah, just a little more health vigilance, I think, would be the idea here.
I got to bring this around to like military readiness issues. I am still in the reserve. I think about this kind of stuff. I have my PHA soon. I'm going to have to get screened for testosterone.
Oh yeah, nice.
This raises two things.
You're going to be jacked, dude.
So jacked.
To be fair, I don't know what my testosterone level is. I've never been tested. I've never felt like I needed to be tested. Who knows?
Hey, that makes two of us. I have no idea what my testosterone level is. I have no idea.
Which says a little bit about how much data you need to make good decisions. But
sure.
One that has been weird to me, because I receive messages from people in the military about this. One I've received is, oh, does this mean I can now tell my medical provider that I have been on TRT this whole time? And like the military just didn't know. I have gotten messages like that. That's a funky one. And then the other one is Jordan just described like a pretty normal endocrinologist approved monitoring protocol. As you go on TRT, there's going to be a few month period where we have to like check you more frequently as we titrate or calibrate and we get to the right dosage for you, the frequency, the dose, whatever. And that's exactly how it works in the military, which means during that high frequency testing initial period, you are non-deployable. And
Mhm.
I think we
Oh,
kind of
interesting.
forgot that.
Okay.
Yeah.
I think we
Whoops.
forgot that in this whole process. And I have heard, and this
Hmm.
is secondhand information, but I have heard from multiple medical providers in the military already that they implemented the testing and then immediately canceled it when commanders
Mhm.
realized how many people would be non-deployable for multiple months while they figured out their dosage for the first few months. Because you can still become
Sure.
deployable once you only need to be tested like 6 months or a year or something like that. But during that part where you need to be tested all the time, they can't send you to austere environments where no testing is available. I,
That's interesting. I never thought about that actually, but
Whoops.
yeah, no, I mean, that makes sense. But again, maybe not thought all the way through. I
Yeah.
mean, to your first question, yeah, tell your provider. Like,
yeah.
we're not the enemy. I mean, look, there are bad actors, bad people, bad professionals in every line of work, right? And so I don't pretend that like, oh, you tell your doctor and he's gonna be like, cool, he's gonna dab you up and say, nice, and then out the door. But I want to be working with the full deck of cards here, right? Like if I'm trying to assess like somebody's labs, for example, and generally like what's their health today, how's their health trajectory looking, what do I need to watch out for, whatever. I want to know stuff, right? So like if somebody's withholding, then we get their labs and I'm like, why is this guy's red blood cell count through the roof? This makes no sense, and he's like, oh, well, I'm actually taking, it's not TRT, I'm on high dose testosterone. Like, oh, well, that makes more sense. Let's change things up a little bit. Anyway, so tell your physician, like, they're not your dad or your mom, whatever. You can do what you want. You have autonomy, but like, I want to know the information. The second thing's more interesting. I have no feedback on that. That is, yeah,
Wild side effect.
you would think that that they would have thought that through.
Yeah.
God,
You
wild, wild.
you
Yeah.
would think.
Perverse incentives. My testosterone was low. I can't go.
That's a great point.
Yeah, there you go.
I got to ask because it's been asked. What does this mean for women?
Great question. I mean, well, to be clear, I think women, generally speaking, period, have been underserved and under researched as just a general rule. And that doesn't mean there's no research, and that doesn't mean that
Numbers have been surprisingly good in the last like 5 to 10 years of like ex-phys research, including women. It's
yeah,
it's
yeah, yeah,
worth
yeah. Like
noting. Yeah.
it's getting 100%. When people say there's no research on women, and I'm like, well, actually, I like the actually guy, and I
Actually,
hate being the actually guy. Women with testosterone is pretty interesting. So, particularly in the perimenopausal space, this is becoming a hot topic because it was originally thought that when women hit menopause, right, final menstrual period, body's producing far less estrogen than before. That at the same time, that's when their testosterone production also like kind of fell off a cliff. What we now know is that starting about age 30, their testosterone levels start going down, and then by the time they reach menopause, their testosterone levels already at the lowest it's ever going to get. It's kind of this gradual fall off. There is some thought that some women would benefit from testosterone in the perimenopausal in that transition, and there's some good evidence around really restricted set of symptoms today that may not always be like that. And then there's specific dosing guidelines or whatever. My fear around this, all women over 30 getting tested, is that again, the labs are going to get interpreted in a way that either the clinicians can't parse, or they're going to be flagged low and then be maybe put on something that they don't need. And there are risks there too, especially if monitoring is not up to par. Hirsutism is obviously one of them, so developing some of these secondary male sex characteristics, usually from over treatment. But it, I guess it is equitable to screen both men and women. But my fears are generally in the same place. It's identifying folks who don't don't need the workup, don't need the hormone or whatever, and then they end up getting on it, and then there's some risk
mhm.
there. So I don't know. Maybe there's a reason they didn't ask me, because if they asked me for a policy recommendation, I'd be like, I don't know, man. Ask somebody smarter. And so that's probably why they didn't call me. I think, yeah.
I have to like piggyback on that one for a second to ask, like, if we zoom out from testosterone, because like testosterone for whatever reason gets this like hyperfixation level of attention in the endocrinology world.
Mhm.
If we just talk about like screening for and treating hormone dysfunction stuff, which space do you think needs more attention right now? Testosterone in men or like menopause HRT in women?
Oof. That's a great question. I would say I would say that the prevalence of menopause, period, is much higher than testosterone deficiency,
Mm.
period,
Yeah,
right?
true.
And so within that sort of framework, there are less women who are going through menopause, about to start menopause, just they recently finished menopause, who are being adequately treated with either hormonal therapy or other therapies directly related to menopause than there are men who have real testosterone deficiency who are not being treated. And further, I could even be more aggressive. Now, this is more speculation because I feel pretty confident about that analysis. But if you combine the number of men with testosterone deficiency who are not being treated and the men who don't have testosterone deficiency but are being overtreated, you combine them together, I still think that number's smaller than the amount of women who are in that perimenopausal space before, during, right after, who are not getting the appropriate care. I think it's still higher in women. So I would direct more resources there if it were me looking at the broader community. Now, if I'm in the military and I'm like, okay, well, what is our split of servicemen
Check.
and servicewomen? I think the calculus may change. I just don't know that, and would not hazard a guess because it's going to get me in trouble, and I don't want to do that.
Well, the
But then
military
there
also
will be an
skews
actually
younger too, but yeah.
there will be an actually person, and I don't want that. So
My next question for you has nothing to do with hormones necessarily, or I guess only occasionally has something to do with hormones.
sure,
I in my social media perusings spend most of my time on Instagram because that's where the Mops and Mo's platform is for the most part.
shout out.
But every now and then, Instagram tries to get me to go on Threads, and
Bless,
Oh
and
bless
no,
their hearts.
and sometimes I am weak, and sometimes it's like a tempting enough little placement thing that I want to read the rest of the post, and I click it, and every
sounds
time it's
Threads.
like the worst possible mistake. I just enter into this hellscape of misinformation, disinformation, polarization, like just, and maybe it's because I was never on Twitter. Like I've never been a
Mm,
Twitter guy, so I can't compare to that. And maybe that's just how Twitter was.
We should get on X.
I don't, you, more power to you, Drew. You can do
yeah,
that for the brand. I'm
that's
not
for
going to be
you.
the one.
It's for you, brother.
Uh, but I will say that the diamond in the rough of the Threads hellscape is your page and your constant, and it's not you posting stuff, it's you commenting on other people's stuff and
He's a thread lord.
just demanding evidence for ludicrous claims. And I just want to know what keeps you in that fight, because I have not been able
Is it
to.
the testosterone?
It sounds like a low T kind of thing. Maybe that's my problem. I need to check my T levels. Uh, well, something you got to know about me is I am genuinely and generally curious
Mhm.
about almost everything, but as particularly as it pertains to the human body.
But also just
And
people's mental disorders on the internet.
yeah, and so, but what I have learned, and now I'm 41 years old now, right? A younger me would usually come in hot. This is BS, no, 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 and then whatever. And if and it was a good day out, and here's the study shows, right? One, the person who I'm posting, there's no chance they're engaging,
Yep.
right? And then two, I'm not learning anything, and neither is anybody else reading the damn thing either. They're just like, what a jerk. This guy came in hot, just he tried to be the actually guy. It's helping nobody. It's a waste of my time. Everybody's pissed. I get blocked, so on and so forth. What I have found, it's not a strategy that is designed to change the person's mind, because I think that's generally low likelihood of success.
Mhm.
But if I'm doing it for a teaching moment, and that's generally how I approach these things. The only way I think you can actually fight misinformation when it's already out there. Ahead of time, you'd want more education, you want more scientific literacy, more critical thinking skills. Yes, all of that, 100%. But when it's already out there, I think you have to come at it from a place of, here's how this person arrived at this belief. If I can get them to identify that and stake their claim, then perhaps I can, through the same mechanism, show it's actually this. And even if it doesn't reach the person posting it, it may reach other people who are reading the thing, which is ultimately my goal. That I'm trying to sort of inoculate people, generally speaking, against not only misinformation, but more so, broadly speaking, just like how do you think about complex topics, and or how I think about them, and not to say that it's always right. So my general rule or idea or strategy when I do this, I see somebody post something ridiculous and say, "Oh, what's the best evidence you think for this?" Right? And if they engage, they'll say something, and I'm like, "Oh, what would you predict? What would you predict in some scenario?" What they don't know is that scenario is actually an exact study that I'm thinking of, that I have access to, right? That directly addresses their claim. And then I get them to, again, plant their flag and then show the study, right? And then so at that point, they're either faced with confronting their own sort of, ooh, my belief system was off, which is painful. So I don't expect them to change their mind. But other people, I have the same response, which is cool. When people are like, I see you on Threads, I see you doing this thing. It's good. It's good. I'm like, great. That is what I'm trying to do. I'm trying to, kind of show my work, show my receipts, and it's fun for me. So I guess that's the real reason why I do it. Because I'll tell you what, I started Barbell Medicine in 2012. I love this company. I believe this company is, one of the best things I've ever done. And granted, it's my life's work, right? But I aspire at some point when I sell this or wind this down or whatever it is, I would love to teach at a university, ideally a med school, because I think, they'd be like, "Oh, you're Dr. Guy, like you're one of us." And yeah, that'd be fun. I want to do that. And so to me, this is, I don't know, I'm getting my reps in. It's kind of fun. So it's like sport in a
Nice.
way, but also, yeah, I get to do some teaching. So it's fun. That said, people are assholes on the internet. Just straight up.
We
I was told to kill myself yesterday on
Okay.
Instagram. Yeah.
Yeah, it's pretty heavy.
It was worded in an honestly pretty creative way. It was a military specific way. He said, "Please join the 22 a day."
Oh my God, jeez.
God, dude.
Yeah, I just, you guys have obviously, you're familiar with my work, so you tend to know that I tend to be pretty careful with how I write things, how I deliver things. I try very cautious with how it's all, there are no accidents here. It's very very intentional. And so, for better or worse, the algorithm has been picking up our stuff like a lot, which is cool. Like good news.
I will say, I don't know where you're going with this, but I will say it feels like you've leveled up on figuring out how to produce content that resonates.
Yeah,
I think often about the idea of resonance, like just saying a fact doesn't get anywhere.
Nope.
You have to say it in a way that like sticks in people's brain a little bit, and you're like nailing it a lot lately.
I appreciate you saying that. Yeah, I took some writing classes, creative writing classes. I'm like trying to figure out like how do I tell a story about, look, physiology, biology, it can be boring, but I also think it can be interesting. Right. So, okay, I'm gonna tell a story. Let's see if this works. And so, yeah, to your point, it's been popping off, which is good. But the downside is that you see some people on the internet that I otherwise would have never crossed paths with. And I'm like, did you read the post? Like we put this thing on meniscus, right? There's a whole thing, meniscus versus sham surgery. There's a number of trials that have
I saw
shown.
that.
Yeah, look, unless you have like a meniscus injury where your knee is locking, for example, right? Or very severe instability. There's like a handful of cases where you're like, yeah, surgery is probably the right option. The other time, sham surgery doesn't beat real surgery, right? And it doesn't mean that people who have surgery don't feel better. Never said that. It just means that they don't feel any more better than if they had the sham surgery, because the surgery didn't really do anything. It's like the expectation, the clinical theatrics. I do this whole thing. I tell the whole story, right? It's got 450,000 views right now, all sorts of stuff. And people are commenting now, again, from the nether regions of the internet. I would have never crossed paths with them. They're like, I had my knee operated on. You're an idiot. I'm like, I don't remember saying anywhere in there that if you had your knee operated on, you're a dummy. I didn't say that. Or somebody was like, oh, so this works for ACL tears. And I'm like, again, not about ACLs. Like you just read the thing.
Even the ACL literature is starting to bend more in the direction of like it can heal even without surgical. I've had an ACL surgery and I can say that without getting real mad at like.
Yeah, it happened, or like some guy was like, how would you know? Have you ever, torn your meniscus? I'm like, in fact, I did actually. Yes, I did. But not that I needed to experience every single thing that I know how to treat. Anyway, it is interesting. It's like you want if you're on social media and you're using it to be like a science communicator like we are, you want people to read your stuff, right? That's kind
Yeah.
of like, that's a KPI for you, right? But the problem is, dang it, some of the people reading it, I'm like, can we have a beer?
Yeah.
Can we just talk about this? Like, are we good? Because a guy called me an effing retard. I should unalive myself. And I'm like,
There you go.
whew,
We
that's
we
spicy.
we found, and I don't remember where I got this from, Alex, but this idea that people like to feel informed, they don't actually like to be informed.
Ooh, that's
Yeah.
powerful. I like that.
Yeah. And I think that has helped because Alex engages more in the social media space than I do. Although
Oh,
recently I've
Alex is the
picked it up,
actually guy. He's the
especially on
actually guy.
LinkedIn. Big actually guy,
I,
big policy guy,
yeah, I've been
Okay.
coaching Drew up though. He's
big
started to weigh
policy guy.
in.
I want to ask you though, have you ever changed anyone's mind in a public forum?
Yeah, only because people say, I changed my mind. I'm like, oh my God.
They said it. That's a
What
big
the heck just
Yeah.
happened? This is incredible. Yeah, no, I take my shirt off. It's the whole thing. I play more than a woman. I dance around my kitchen and the whole thing. And so I'm like, this never happens. This is insane. Yeah, very rare. It's hen's teeth. That's the whole thing. I never go into a comment section on my own post expecting that I'm going to change somebody's mind. But one thing that has changed recently, actually, I'm gonna say two things. You know how the New Year's resolution comes around, right? It's
Uh-huh.
January 2nd, January 3rd, and people are like, hey, what was your New Year's resolution? I don't ask that question. I don't care. I ask a different question. I ask, hey, what are you most proud of yourself from the last year?
Nice.
Just curious. And so somebody asked that back to me, and I think about it. What I was proud for last year, I had a pretty tough year, some interpersonal stuff and whatnot. But my goal that year, 2025, was to be more kind to people, right? No matter what I was dealing with, I just want to be more kind. And being on the internet all the time, it is very easy to be aggressive and snap back at people, whatever. You could just take out everything because you don't know the person you're behind a keyboard, it's whatever. So it's been this conscious effort just to treat other people how I wanted to be treated all the time. Now that sounds simple, harder to do in practice. But anyway, I get so many comments from people that are like, the way that you are level headed in your own comment section when people are attacking you or whatever, and you're just explaining things, asking them questions, genuinely interacting. I'm like, yeah, I didn't like put a list down of what I was going to do, but that's how it's turned out. And I tell you
Nice.
what, it seems to be paying off with these people because genuinely when you kind of de-escalate and you kind of walk them through stuff, I'm not thinking that I'm changing their mind per se, but I do think they come at it from a position like, oh, this guy's not a jerk. He just has a difference of
Mhm.
opinions or sees things differently or has a different experience, whatever. And so the best tell is not when someone says, oh, you changed my mind. They start following me. Even though we just had a little argument in the comment section,
That's a
like,
good point.
I got you, bro. I
What
got
else
you
is he
now.
saying?
Yeah, I got you now. Wait for that discount code. I'm gonna see that. I'm gonna see that. No, no, I'm kidding. But
This is forcing some self-reflection for me because one of my biggest weaknesses is I have a hard time. I attend almost every fight I'm invited to.
Mhm.
oh, nice.
I, and I've had Drew's watched me go through the journey of like I don't really mess with the DMs anymore.
Yeah, no.
I just kind of leave though. Like there's an auto reply that says, "Here's my email address. Send me a note if you got something real," and they almost never care enough to do that.
Mm.
Um, but like in the comments, I still do come in too hot. Like I do. Um,
Yeah. Look,
mm,
this is a skill. Like if you go through this recent pregnancy post or the meniscus post or whatever, and you see some of the stuff that people are writing, and then I'm not saying that my replies are perfect example. I'm not an exemplar all the time because obviously I'm a human and I have emotions or whatever. But I try to be as charitable as possible because I do think that ignorance is the more likely sort of source of what they're saying than hate or anger or ill
Mhm.
intent, right? They don't know. How would they know? If they knew
Mhm.
what I knew, they would probably have a similar opinion. At least that's kind of how I think about it. And further, I might not know something about their, what they're actually trying to say. And so, that's kind of the framework I work through. But again, not perfect. And I too, like you, Alex, I attend every fight that I am invited to. But you know what it is? It's the freaking algorithm. The
Yeah,
algorithm
man.
rewards that. They want me to comment. And so I had to find a way that where I could do it and live with myself.
You
So
need to read, we just reached out to have this guy on. He wrote The Game is the name of the book. C. Tai Nguyen, I believe.
yeah.
oh,
THI.
oh, Oh, okay. Not the game with like mystery from the
No,
dating
no, no,
show.
no. It's
The
called the
different
game. It's a new, but it literally, to your point, his and I just started reading it, but his philosophy guy gets into philosophy and realizes it's all about publications. It's not about answering the big questions. Once you pursue the metric that defines your field, you forget why you love the field in the first place. And
Yeah.
talks a lot about social media and that exact thing. It's like it's the likes, it's the engagement, it's not the conversation, which is why you entered the space in the first place.
I
Yeah.
I will hit two others though real fast. One, I'll plug a book I read years ago called How Minds Change by David McRaney.
Great.
It's a great one.
That would be a good
Um,
one.
two, I hear that it's the algorithm thing all the time, and I get a little frustrated because it feels like giving up a lot of human agency. I I don't I try not to blame the algorithm because all the algorithm is doing is manipulating our worst impulses. Those just happen
Mhm.
to be our most powerful impulses.
Yeah.
Um,
Yeah, well, it's interesting because it's like, if it, yeah, that's actually a great point because it's like on testosterone, for example, I've had hitters write these posts that just
Mhm.
land, resonate, go crazy about testosterone, right? And other ones that do nothing. And I'm like, the material it's not that it's the same, but it's an analogous. What was
Mhm.
the difference here? And generally speaking, for at least for in my little niche, my little corner of the internet, my little armpit of the internet, it's I have to tell a story that a person identifies himself within that character and then walk them through something like a pain point that they felt and either resolve it or find a villain and then blame the villain, right? And people are like, yes, this is me. And occasionally I become the villain. Like that happens too. That's fair.
Mhm.
But yeah, to your point, when I and still sometimes do feel like I'm blaming the algorithm, it's mostly a reflection on me and like not the
Mhm.
quality of my work per se, but the way it's being presented. And so, yeah, my only annoyance with the algorithm is as follows. You post something, you want people to comment immediately, and you have to reply to the damn comments. So I
Mhm.
can't just post something and then go off about my day and like pretend that nothing's happening. I got to be tethered, for a little bit just to get the thing to go. Otherwise, why am I posting in the first place? That is my only annoyance.
Mm.
Uh, that and people who don't let you mention them back in the comments after they're a jerk
hate
to
that.
you.
Hate that.
Come on, bro.
Yeah, that's not cool.
Yeah, look,
And some
if
of the
we're gonna
biggest haters do that.
yeah, if you're asking me to meet at the flagpole at 3, I'll be there. But, like, don't send a proxy or hologram. Show up yourself. Come on,
Yeah.
man. Anyway.
Uh, Last one, we're already over an hour. I wanted to sneak one other in before Drew brings us to a close here. I've heard you use the same phrase a bunch of times recently, and I like it. So I want to give you a chance to like do the stump speech thing. Your quote is, "Your grip is your muscles BMI."
Oh, yeah.
I just want to give you a chance to do that one.
Yeah, yeah. So, okay, to explain where what I'm saying about that, your BMI, generally speaking, is supposed to be a screening tool for obesity. And it's a blunt tool, right? You're looking at a house, you're only at the curb, right? And so, in my house analogy, your garage is the subcutaneous fat stores, right? And again, some people have double garage, some people got a single garage, some people got no garage at all, right? But from the curb, you can't really tell what's going on inside the house. And the BMI, what it's supposed to do is identify people whose garages are not only overflowing with boxes, right? But that it has boxes in places they shouldn't be. And those boxes are not turning over all the time. I'll give you an example, actually, in physiology. Muscle fat, having intramyocellular fat, lipids in your actual muscle tissue is not necessarily pathological. For example, individuals with severe metabolic disease, frank obesity, they'll have fat in their muscle, right? The Semmeline study put these individuals with an average BMI of about 46, I believe they started with, on max dose semaglutide, Ozempic, over a year, right? And then they did these tests to see, hey, look, what happened to their muscle? What happened to their grip strength? They lost a bunch of intramuscular fat. Their grip strength went up despite not training. Okay. So the problem here in obesity is that those boxes, the fat ends up in the muscle, but it's not turning over enough.
Mm.
Endurance athletes have a ton of fat in their muscle too, but it's turning over like crazy. So it's not just that the fat is there, it's that the fat is the place it shouldn't be and it's sedentary. But BMI can't tell you that. All BMI says, from the curb is like, hey, they have a garage and the garage looks a little janky. That's all it can tell you. All right. Grip strength is similar because it is such a downstream sort of measurement, meaning that you've got your neuraxis, so from your brain to your spinal cord to the nerves to the muscles, the bones, all of that has to be intact and working orderly for you to grip something hard, right? So your grip strength is generally supposed to be a predictor of like, hey, is your musculoskeletal system in order? Are you have enough muscle mass? Are you strong enough? But it's really a readout of all of that stuff together. And further, it doesn't dissociate from the actual genetics themselves. Most of people's grip strength related to two things. One, straight up genes, and two, how big they are. Okay.
Mm.
And so, because those are the two things predicting grip strength, you could actually remove the grip strength measurement and just look at genetics and how big a person is and get a similar sort of readout. It doesn't tell you the fine data that you're looking for, which in this case of strength is like, hey, are you missing enough muscular function where you're now at risk of falls, where you're now at risk of being too weak to live independently? It's too blunt of an instrument. So if you had to use something like grip strength to measure muscle mass, really more muscular function, sarcopenia actually is a terrible term for the disease. Sarcopenia, people will say, well, look, it's just a disease, an age related loss of muscle mass. And it's like, it's not actually that. All the definitions now are it's a loss of muscle function, which we think is a neurological disease. When people don't exercise, they lose these fast twitch motor neurons. And so, because they lose that, they can't produce a lot of force. And more importantly, especially for older individuals, they can't produce a lot of force quickly, right? So, you would want a better test for that. You would want like a timed up and go where you get somebody to stand up out of a chair and walk and you time it and you see how they do it. You would do a set of 5 sit to stands. They get up and out of a chair without using their arms. Can they do that in, less than 15 or 20 seconds, something like that? But if you had to use grip strength, it's not very useful until it's too low where somebody's already down
Mm.
that path a little too far. You could use something like a relative grip strength, which is your grip strength related to your weight, right? Because now you're correcting for how much mass does somebody carry. You could use grip power, how fast you can close, because that's a little bit more discerning. The problem is there's not a bunch of data sets on that. So I'm not like an anti grip strength person insofar as like it does have some predictive power, but it's really a genetic thing and how big the person is. And then, so it's not terribly useful until it gets too low. The other thing I don't like about grip strength, it doesn't really go up when people train. So,
Mm.
like, you, unless you train your grip
Mhm.
specifically, in which case, all you're doing is playing to the test, but that's
Yep.
no longer predictive. You're basically inflating a number without getting the benefits. And so it's like, I asked Austin on our podcast we did about Dr. Baraki on our podcast we did about grip strength. I'm like, look, would you rather somebody do, squat, bench, deadlift, or leg press, chest press, whatever? They get 20% stronger, but their grip strength didn't budge. Or they do all this grip strength training, their grip strength goes up by 20%, but they didn't get stronger on a leg press, on a chest press, or whatever. Obviously, these are artificial situations. He goes,
Mhm.
well, I don't give a shit about their grip strength. I care about their actual function, which is more predicted by what's their leg press, what's their chest press, so on and so forth. So all it is that both are very crude tools that aren't really telling you what you're like exactly what
Mhm.
you're looking for. And so they're analogous that way, but still can be useful as a screening tool, which is kind of how I ended up. And people hated that. They universally hated it. They're like, BMI is stupid. It's, racist and whatever. I'm like,
I got in that exact fight like a week and a half ago. Yeah.
yeah. Yeah. Like, look, I get it's not perfect, but
It's
also
still better than trying to DEXA every human on the planet
yeah.
because
So
it's
when
just
people are
not
like,
going
oh,
to
what's
happen.
the so yeah, look, if you bought into my garage analogy, I know we got time, we're on a time clock, but if you bought in my garage analogy, and you're like, okay, the definition of obesity is excess adiposity, and excess means that you have fat going into places it shouldn't be and it's staying there. Well, how would you identify that? And then I would have to confess, I'm like, well, you'd have to do some really extensive testing that does not exist outside of a research lab, or
Mhm.
every other test that we have is after the fact. We cannot predict until after the fact. And in this case, a BMI of 30 is after the fact too, but doesn't cost anything. That's the thing. It's cheap, easy. We have data on all sorts of different populations, so it's okay. The biggest problem with the BMI of 30 is that it's such a blunt tool, you're going to miss about half of people who
Yeah.
are carrying too much body fat, but they don't have a BMI of 30 yet. And some people who have a BMI of 30 or above, their fat is all stored in a garage. They got a big garage, so they're good to go, right? So yeah, it's not perfect, but tell me a better metric. I'll tell
Mhm.
people to do it. That's also cheap, doesn't require lab testing, doesn't require people to spend money, and we'll do it. You can make an argument for a waist to height ratio.
There you go.
which the military has just done. Yep.
Yeah, you can make that case. It's okay, but it doesn't like dunk on BMI. And so I would do both, right? If I had
Yeah.
a person with a BMI, let's say of 27, I'm like, okay, well they're not over 30, so I'm kind of curious. I would get a waist circumference, and the waist circumference would tell me, or a waist to height ratio would also tell me, and that's fine. So you're getting both. The body roundness index is pretty interesting as well, although it does need to rebrand because
hmm
who's
It's a
going to
rough
submit?
name.
Who's
Yeah.
going to submit to that? They were coming up with the name. They're like, what's the most
BRI,
inflammatory term that we can come up with? Like,
the fatback index,
that's what I'm saying, right? Like, that must have been the first choice. They're like, no, we can't do that. We got to do body
body
roundness.
roundness.
Yeah. The whole point, though, is when you have tools that can be manipulated in ways that don't correlate to the outcome you're looking for, that's a problem. And when they're too blunt, that's also a problem. And that is, in fact, the case with both BMI and hand grip. Doesn't mean you throw the baby out with the bathwater. They're just imperfect tests, and,
Mhm.
and that's that.
I just got to vent about how hard it is to do in real life. Like, I work in military populations, and in military populations, people assume that like every metric that's recorded about them is a value judgment. And so
Yeah.
I do a
Sure.
lot of waist height ratio testing, or my team does sometimes. I don't do it as often. I have done hundreds of grip strength tests in the last few months because I'm an investigator on a study that includes that. But like, yeah, I mean, it's exactly what you said. Every guy I've tested who's taller than 6'6" blows it out of the water.
Mhm.
But I've also tested like a guy who weighs like 140 and is a world class power lifter. Like, like he weighs 140 and deadlifts like 700 or something. It's disgusting. And his grip strength is like 100 pounds. Like, it's
Yeah.
like nothing. And like,
Yeah.
it's not so low I'm worried about it, but it's also not remotely high. It's not as high as mine, and I'm not nearly as strong as him. So it's
But
just
you just
this
carry
like,
more muscle. Yeah.
I
There's
don't know.
there was an interesting study with grip strength. This is the last study. I swear to you, I did not. No more studies were studied out. They looked at, it was weightlifters, masters weightlifters, as I recall, and their dominant hands grip
Mhm.
strength were no better than healthy age adjusted controls in the general population. You're like, well, these are weightlifters. Come on, they use their grip, hook grip. They should be better. Where they actually differed was their non-dominant hand was
Hmm.
significantly
Hmm.
stronger. There was less asymmetry. So there was a thought that, ooh, maybe we measure grip strength on both hands and there's an asymmetry
Let's do
index.
more grip.
Yeah.
Yeah, what's better than one grip strength level?
Two
More
grips.
grip. Yeah, exactly. Two grips. Yeah. Okay. Not funny.
So let me ask you, and we've I think touched on this. Obviously, we've touched on this. The whole podcast was about this. Had Pete Hegseth called you, had they come to you and had they said, "Hey, man, the military has a low T problem," what would you do?
Yeah, I think that's a great question. And again, this is off the cuff. I've not
Sure.
rehearsed this, so my apologies for any rambling and repeats. I think it's reasonable to want to ask the question, "Hey, are our servicemen and women, is there a hormonal problem here?" I think that is a reasonable question. I don't think that the lab test is what would answer that for me, or further, what would be useful at flagging people who deserve the full workup. I would use symptoms. I would just have like a standard battery of symptoms. You're going to do it yearly anyway. You're taking an inventory. It's free. You don't got to go to the lab. It's less sort of subject to change, wherein if you have a person who has a low testosterone value, at a lab test, well, now you've committed them to a second lab test. And most of the time, the majority of the time, it actually kind of fixes itself on its own. And if they don't get that secondary test and they commit themselves to treatment, well, now you've put that person in the scope. There. What is that called? Not the bullseye. I'm so bad
Oh,
with weapons.
the
Oh,
I
Maybe
can't think
edit
of
this.
the
Anyway, you put them in the crosshairs.
crosshairs.
there it
Got it.
is.
I
There
was
you
gonna
go.
For a
for
military
no good
podcast,
benefit.
we really whiffed that one.
Yeah, my bad.
Yeah.
Yeah, you can see. Yeah, no, my conceal and carry instructor would be very upset with me. Anyway, so you've committed to that because you picked a lab and not symptoms. So that's thing one that I would do from like the assessment standpoint. You could make the argument that collecting all this data, you feed it into machine learning, and over decades and decades, you find some interesting patterns. I'm a little bullish on that, but okay, whatever. Let's do symptoms. That's what I would have done. That's what I would have recommended. And then further, I would have made a push for, look, if you think there's a problem, and even your own data that you have right now suggests that there is one, particularly when you put people in austere environments, fix the environment to the extent you can, right? You can't, look, when you're underway or you're out in battle, you're on the field, you're kind of chalking that up as like, look, well, you're not going to treat somebody acutely with testosterone anyway. You tried that, it didn't work. Those things are true. But when people are not in those environments, then you'd really want to make sure the environment is conducive for rest, recovery, and overall health, which is ultimately what testosterone is going to be a readout of anyway. So I think those would be, if I would go through the food supply, I would go through sleep, allocations, these sort of things. And I think ultimately the healthier you can make the military population, the less testosterone concerns you're going to have. So to the extent there is a testosterone problem, it's a military health problem. And I don't think you fix that with taxane.
For listeners at home, Dr. Feigenbaum has just reinforced one of Drew's
I'm keeping my mouth
fundamental.
shut on purpose.
It's one of Drew's fundamental theses about military health and performance, which is that we say we want more information, but we are unwilling to take the actions that the information actually supports taking. So no amount of information will solve that problem if we are unwilling to do the fundamental things that everything points towards doing.
Seems like it.
All
Seems
right,
like it.
on to more serious questions, perhaps the two most serious questions we've asked thus far. And as a powerlifter, I want to remove back squat and bench press from your possible list of answers.
Okay.
Favorite lower body exercise, favorite upper body exercise.
I mean, I'm picking deadlifts. I am. So
I wanted to give you that.
I was going to tell Drew to remove that too because it's obvious.
Okay, fine. Take away all three.
No big three.
Okay, none of the big three for the lower body. I'm doing a front foot elevated split squat.
Oh,
yeah.
I like that. A lot.
I mean, you could pick Bulgarians. The thing is, I just prefer my front foot to be elevated because I feel like I personally can load that better. This is actually a great question. So what makes a good exercise, right?
Here we go.
I have criteria. For this. And I call it needs to be trainable, which means that you can do the thing with reasonable technique. So the technique is relatively repeatable, it's efficient, meets the points of performance, right? So for example, I can't front squat worth shit. And it's not because I haven't tried. It's just my arms, the way it is. I have a terrible front rack. And so while I have squatted 660 pounds with a bar on my back, right, I can barely front squat 405. And people are like, oh, well, that's still a good front squat. I'm like, yeah, but I can't train it as well, as frequently, and as hard as I can the back squat. And ultimately the load on the legs is, a little bit, I can do more training load with the back squat, not just weight, but sets, reps, etc., all that sort of stuff, right? So it needs to be trainable. It needs to not cause you a bunch of pain when you do it, and you have to enjoy doing it. So you do a ton of it, because my goal as a coach when I'm coaching somebody is to get them to do the most amount of training load possible, where training load is not just the amount of work that you're doing, but the nature of it. The exercise selection, the intensity, proximity to failure, so on and so forth, right? So how much training load can I do? And I'm going to do more training load with a back squat than I am a front squat. You can take that out of the picture. I have to pick another lower body exercise that's not a deadlift. It's still going to be free weight for me, and a front foot elevated split squat would be my thing. I usually do it 2 or 3 inches elevated in the front. I really try to stay vertical and slide all the way forward. I get a ton of knee flexion, ton of hip flexion. There you go. I've done, 120s. All right. So that's my lower body thing. The upper body can't be bench press.
Yep.
Can it be incline bench press?
I knew we were going to get into this debate. Sure.
If it wasn't incline, I'm doing dips. So
nice.
Yeah.
Okay. Yeah.
Yeah. Mainly because okay. And just look, I've been impressing dudes since 1985. I'm really good at impressing dudes on dips because they think like I'm now unk status. I'm not chopped unk status, but I'm unk status for sure as a 41-year-old.
This is a guy who's been on Threads too much.
100%. Yeah. Yeah. I'm a man of culture.
Man of the people.
But look, I can strap, 3 plates to my person and do sets of 8 to 12. And people are like, how does he do that? And I'm like, look, I'm a little muscle nugget. I'm 5'10", 205. I'm a little muscle nugget. What do you think? What do you think I'm going to do? All right. And I like the dip. So that's what I would pick. If I can't pick
a t-shirt that says muscle nugget, is that in the Barbell Medicine apparel?
Man, next release. Yeah. Look out for it.
Hell yeah. I'll buy a muscle nugget t-shirt. Shit.
You got to achieve muscle nugget status before you can buy the
Ringer
t-shirt.
T? Oof.
What are you picking? Like hip thrust and like pull-ups or something?
Have we
Drew,
picked?
don't burn this because we said we were going to do an episode where we talked about our
Okay.
favorite
All right, fair enough.
exercises.
Oh, that's a good point. Yeah,
Got to
we
be
can't.
careful how much you use
We
up here.
did. We did
content.
create a fitness aptitude test, which we called the FAT.
Body
That-
roundness index.
Exactly. That was max pull-ups. I think was it a 1 or 3 rep max deadlift and then a 5-mile run.
How do you max? Okay, well, I'm getting smoked. Running is so hard.
Well, yeah, when you're a muscle nugget.
Okay,
I will say this is a good back and forth here because Jordan and I are the exact same height and Jordan weighs 40 pounds more than me. I will take him on the 5-mile run every time.
Yeah. Look, but we get on a bike and we make it a 20-mile ride.
That is true. I forget you had like a bike thing there going.
I'm a demon on a bike, but the running, I am a rhinoceros. And like the slow one, like the one who's getting eaten. Like you're like, how could possibly a lion take down this rhino? I'm that rhino. Like, he's just.
Might I then request a muscle nugget lycra cycling jersey on behalf of Barbell Medicine? Yeah, I will buy one. Hear me now. I will buy one of those.
Done deal. My fitness aptitude test would be a 1 rep max deadlift. It would be like a wattage output on a bike, and then how far you can hit a golf ball. That's like my.
I'm in for that.
No conditioning component. Just whatever, dude.
I love that.
Yeah. There you go.
Well, sir, it's been a pleasure. Thanks for putting out testosterone information in an incredibly timely manner for the military. And thanks for hanging out with us.
Yeah, thanks for having me, guys. This is the one plug. Can I make a plug? One plug?
Please.
Send it.
Yeah, we just published our first book. It's called Signal, what your testosterone is telling you about your health. This is not like trying to sell everybody on TRT or steer everybody away from TRT, but all of the information that we talked about here related to testosterone and much, much more, plus menopause, plus testosterone in women, all that sort of stuff, the history, it's in this book. I try to write it in an entertaining way, so it's not just facts and figures. Pick it up, support the brand, or torrent it off the web somewhere, like whatever. Just read it. It's fine.
Don't just feel informed, gang. Be informed.
Not to spoil the history, you will learn about where this all started. And it started with
wild story.
A Frenchman injecting extract of testicle from animals.
Like ground up balls. Yeah. Love it.
Boom. The team, welcome to the after party. I don't know how much of that just made it in, but we were screwing around with camera stuff. Now we seem incredibly close.
Does it feel more intimate now?
It does.
I can switch it while you're talking and see if you can handle it.
Listen, 4 years on, I'm a pro at this point. One, I like hanging out with Jordan because he's very smart. Two, I think, and I want to be safe here, I think my biggest takeaway from this conversation is that the military might have jumped the gun, no pun intended, or dropped the ball, also no pun intended.
We didn't do enough ball puns.
I know, we could have done better. In fact, we should have let him know ahead of time that we wanted to do that and see how many we could have gotten in as a team. But yeah, it feels like we're in pursuit of a number at the expense of perhaps causing harm to what that number is meant to actually signify, which is like presumably higher quality of life, et cetera, et cetera, et cetera.
You know how I know somebody's a good one for the podcast is when they have posts on their Instagram where the caption is just Goodhart's Law.
Yeah.
He did that within the last couple of days, I think. I'd have to go back and check when it was, but
we're a big fan of Goodhart.
It's a theme that it seems to appear in a lot of people's content lately. So I'm like, I'm not saying like we got there first, but like
we're influencing. Or the algorithm.
We've been talking about Goodhart's Law.
Just feeding us people like us. I don't know. Where do you stand on testosterone?
I mean, I think my main takeaway, which should not be a shock to people, but like sometimes is, I guess, is that endocrinology is complicated.
Yeah.
I think, and frankly, this is something like we were a little bit guilty of in this episode, is like hyperfixation on individual hormones rather than the interplay of multiple different hormones. Letting testosterone drive the conversation with like estrogen as like a end note and then no discussion of any other hormones.
Mm-hmm.
There's just, I don't think hormone health lends itself to one-page memos to solve the problem for multiple millions of people.
Yeah, and and again, I don't want to get in trouble saying this, but I just can't help but think that a lot of this, we talked about stories and narratives, and like there is this narrative that we are less manly, we're less lethal, we're less like, and without getting political on this whole thing, like there's kind of been this through line of like everything's in decline. We have to fix it all. And this to me, like it's easy to fixate on a number, that number being testosterone, because that's sort of what, if pop endocrinology is such a thing, that's what it fixates on. And it's like, if we just jack up this number, then second, third, fourth order effects will be that everything else is fixed. But I think we said it there at the end, and not to like spotlight myself, but it goes back to that concept of if all the data is showing you what the problem is, are you willing to fix the problem, or are you just going to kind of band-aid it? And to me, jacking up T levels, as laid out by Jordan just now, it's just it's a band-aid. In some cases, it's a band-aid you might not even need. But to be fair to the other side of the argument, like there will be folks that benefit from this policy. So I can't just knock the whole thing.
Well, I think I'm going to quote from Jordan's book, right? Men are, and this is specific to men. Sorry, it's a testosterone episode. But the quote is, men are being medicated for problems they do not have, missing problems they do have, and trying to interpret labs without a clear framework for what those labs actually mean. And I think Jordan said it a couple times in our chat, like we're missing it on both ends. We're missing like people who should be treated that aren't, and then we're missing people who are being treated that shouldn't be. And so it's just like narrowing it in. And I think I've said this on the Instagram, but like the people I am worried about in this whole process are the frontline providers in military healthcare and the presumably very few actual endocrinologists we have working in the military. I can't imagine there are that many of them. Their workload just skyrocketed. So good luck.
Yeah, Godspeed. This one goes out to you guys. Well, I'm going to go shoot up with testosterone. And see you guys next week. This week's episode is brought to you by Teamworks. Training, nutrition, scheduling, and communication. One platform, every domain, every role. Teamworks unifies human performance for the service member and the command. Learn more today at teamworkstactical.com.
Hey, Alex, let's cover our ass real quick.
Oh, great idea, Drew. All right, guys. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent.
Thanks for tuning into this week's episode. Before you go, please rate and review the pod on the listening platform of your choice. You can also visit us on our website at www.mopsinmos.com. That's mops, the letter N, mos.com. You can check out the library of podcast episodes, our latest blog entries, any helpful resources, and also sign up for our newsletter.
Drew nailed it. Just to underline a couple of things, the podcast entries have in-depth show notes on the website. So if you missed anything or you want to read any of the research we talk about, it is all there. You can, at the bottom of the website, sign up with your email and receive future updates from us. The blog posts go a little bit more in depth in kind of written form on a couple of topics we get questions about all the time. But most importantly, I just want to ask all you guys, our best way the word gets out is absolutely word of mouth. So tell your friends, tell the people you work with, anybody you think would find it useful. Thanks for spreading the word.
If you have any questions or comments, feel free to shoot us an email at either Drew or Alex at mopsinmos.com.
Or there's a contact form on the website.
Thank you.